Okay, so good morning. Today we are going to start this review of the neoplasms of the prostate. We're just doing a brief review of the normal anatomy. And as you well remember, the location of the prostate in the pelvis. This is a nice picture taken from a cadaver in which a block of the pelvis was shredded about 50 microns at a time, and we were able to take pictures. Then later on, we did a three-dimensional reconstruction. But the prostate is a nice way to show the anatomical location regarding the rectum. That is the way that we can approach the prostate through the posterior aspect. You can see the seminal vesicles and the bundles that are at either one of the posterolateral sides of the prostate, where the uh, main nerves that are in charge of sexual intercourse, especially for in the process of erection, that when these areas are altered, that will create, as you can understand, sexual impotence. And this is something that we are always being considered in regards to radical procedures with the prostate, when they have to remove these bundles because of the presence of cancer, especially if the cancer is extra prostatic and it's gone beyond the limits of the prostate. And you can also see the bladder here that was filled with a blue colloid, and the muscles in the pelvis with bone, etc., uh, and the urethra itself. So this prostate, we can create these kind of cartoons where we are representing the basic locations of the glands with different morphologies, as we are going to see there soon in regards to the histology. The urethra has this angulation that goes from the anterior aspect of the bladder, and then posteriorly it becomes angulated to go into the penile urethra. The uh, central zone is immediately behind this transitional zone that is easier to approach when we do transrectal biopsies from the posterior aspect. And then we also have the peripheral zone. The important take of this graphic is that the transition zone is the one that is going to grow in the adult to produce the benign prostatic hyperplasia or nodular prostatic hyperplasia. And as compared with the younger people, this transitional zone that is relatively small around the urethra is going to grow, pushing away the central zone, the peripheral zone. And the peripheral zone is also important because most of the cancers are going to arise in this area as well. We can play with some different ways to represent this urethra with the central zone here in blue and the transitional zone in orange, and the peripheral zone as well here in gray. If we make sections at the different levels, as we usually do when we do our whole prostatectomies, I'm sorry, the whole prostatectomy procedures that you are familiar with as well, use this approach of cross-section from apex to base, in which we can also see the representation of the peripheral zone in regards to the central zone and the transitional zone. In the center, the urethra with the verum montanum, and here in the posterior aspect of the prostate, the ejaculatory ducts that are going to come from some superior to lower levels. Almost at the middle of the prostate, they are going to angulate and they are going to connect with the urethra, producing through this verum montanum. The anterior aspect of the prostate is important because it's mostly fibromuscular stroma, but there are also some glands here. And when we have cancer arising in this area, sometimes it's very difficult to detect because the needles that come from the posterior aspect of the prostate are not going to be able to reach these anterior cancers, especially when the prostate has some enlargement. This is another kind of a Lego way to dissect the prostate and the transitional zone in regards to the urethra, with the angulation, the location of the seminal vesicles, with the ejaculatory ducts that are connected to the urethra, and then the um, uh, transitional zone with the peripheral zone as well. So here are some examples in regards to this histology. And first of all, I want to make an emphasis. If you're going to be in a private practice, you need to have very good relationship with your technicians, and you're the ones who have to lead the way that these tissues need to be processed. For example, these are coming from an outside pathology laboratory where they decided to throw a bunch of needle core biopsies that are many times overlapping and very difficult to put at the same level, creating problems in the interpretation and also missing sometimes areas of important value for the detection of cancer. And this is another one as well. And this is the way we do our biopsies. We don't put more than 2 or 3 cores per slide. And if we have more cores, we try to put them in different cassettes. So that allows us to put them in a nice way, all at the same level. And also, when you do the screening under the microscope, they are easier to follow without missing any part of the specimen. So here we have some examples of the peripheral zone. They are very simple glands, and as you know, they are layered with 2 cell layers, the basal layer and the glandular layer. And the cancer is going to be originating in the glandular layer, with, I don't know any case of basal cell carcinoma of the prostate. These basal cells are usually hyperplastic, but the wave to become malignant is very rare. Here we have, in contrast, another area that looks completely different, where the glands are very complex. We could define them as glands within glands, and in many cases, especially people who are not very well trained, may confuse these central zone glands with cancer sometimes, or with PIN, with high-grade prostatic intraepithelial neoplasia. And these glands, when you see them under higher power, they may have a small nucleoli that can also further confuse the beginner pathologists, thinking that this can be high-grade PIN. And we have many, many cases that we see, especially from outside laboratories, in which these glands have been called high-grade PIN. This is another close-up where you can see the complexity of these glands, that sometimes they may have a small nucleoli. Another caveat that we need to be aware of is the presence of a seminal vesicle. Seminal vesicles look very ugly, and they have very they look like a very atypical nuclei, as you can see here, with different sizes. And one clue is to look for this kind of a golden inclusions in the cytoplasm of these cells. It's important to mention the presence of seminal vesicle tissue when you have a prostate biopsy, because many times the urologist is trying to sample the seminal vesicle. And sometimes they can mention in the identification of the specimen that they are taking samples from the seminal vesicles. Sometimes they don't. But if you find seminal vesicles, it's good, even if the whole core is negative, it's good to mention that the seminal vesicles are present in the specimen. As you can see here, this big nucleus in this sample is completely normal within the seminal vesicles, and we don't want to confuse it with a malignancy. Here is another example of another area of a section of seminal vesicle as well. Also, we can find neurons, and they have very prominent nucleoli, so don't confuse them with cancer. They have the very nice amount of cytoplasm, and sometimes they have some melanin pigments that may help you to identify them, but they are typical clusters that usually are outside of the prostate. Sometimes they are inside, but when you have this kind of a tissue, be aware that especially if they are invaded with cancer, that you may be facing some extraprostatic extension. This is another nice paraganglion that has been sampled, but this is from a whole mount. It's not a biopsy. This is areas surrounded by fat outside of the prostate, and you should be able to recognize them as well. So in regards to benign lesions, the most important benign lesion in the prostate, especially in individuals after 40, is inflammation. Here we have chronic inflammation, that is the most common, but we can also find acute inflammation. And particularly in my case, I always like to mention the presence of acute inflammation. Probably chronic inflammation, we can mention it just for academic purposes, but in regards to acute inflammation, this is one of the most common causes of increased PSA. So many patients are being biopsied by the urologist because they have an increased PSA, and many times this PSA is increased either because of this inflammation or the size of the prostate, and that's the reason why we do the biopsy. But if we ignore in our reports the mentioning this acute inflammation, then I think we are lacking in regards to clinical pathology correlation, because this is an important element that can be related with the increased PSA. As you can see here, this epithelium is loaded with neutrophils, and the presence of this inflammatory process is what is increasing the PSA. This is another kind of a small abscess inside the prostatic gland in the transitional zone. So I would suggest you always to mention the acute inflammation if you find it, especially if there is an abscess of cancer. So at least there is some way of correlating that elevated PSA. Another kind of interesting inflammatory process is granulomas. These granulomas can be just related with some atrophy of the prostate. We are going to see it more often, especially in patients who have been treated with BCG because of bladder cancer. And then the prostate gets also infected by the BCG, and they can produce this kind of granuloma. And this particular granuloma doesn't have necrosis. Usually the BCG-induced granulomas are going to have central necrosis. And the famous corpora amylaceae, that they are layering of secretions that are stuck inside the gland, and then through months and years are going to be producing this kind of small pearls of hard material that eventually they're going to become like little stones inside the prostate. These corpora amylaceae take, as I said, many months or years to develop, and usually they are not present inside cancer, because cancer is supposed to be dividing rapidly. And if you see an atypical gland with the presence of this kind of corpora amylaceae, most likely it's going to be a benign process. This is the extreme corpora amylaceae that became calcified, and is also important to differentiate it. And also crystalloids. Crystalloids may be present in cancer and may help you to in the identification, but they are not pathognomonic of cancer. This is a normal gland from the central zone. As you can see, that is very complex, but it has this crystalloid that is just also a way of the secretions that are becoming dehydrated and then crystallized. Sometimes we may find this kind of stromal nodules. This is in particular, this is a cancer. This is 3+3, but still, these stromal nodules may be associated They don't make any significant difference. Nobody has been able to find any kind of different behavior because of the presence of these stromal nodules, but be aware that sometimes they may be present either in normal tissues or in cancer tissues. And then we go into the hyperplasia. Uh, uh, Sometimes we call hypertrophy of the gland, but hypertrophy means that it just grows in size, but not in number. But the prostate really grows in number of cells, both at the stromal level as well as the glandular level. Here they are just gross examples of these big nodules in these partial prostatectomies, or then in whole prostatectomy, where you can see these nodules. They're mostly in the area of the peripheral zone. That is the one, as I mentioned before, that are going to produce this enlargement. And here you can see the different classifications of these nodules based on the amount of the cell type that they are going to have. Many times we are going to have just very pure mesenchymal or fibroblastic or smooth cells in this hyperplasia that is mostly leiomyomas, very similar to the ones that are present in the uterus. But they can also be very rich in secretory cells. But usually they are a combination with a mix with stromal and glandular components, with some variations in regards to the way that they appear under the microscope, if they're cribriform or small cell or basal cell hyperplasia. This is just a low power of one of these sections of the prostate. And you can see the central zone is significantly enlarged, as I'm outlining here. The urethra is here in the center with the verum montanum and the connection with the ejaculatory ducts at this particular level. And then the peripheral zone and the central zone are going to be squeezed and pushed out of the prostate, producing this flattening and atrophy in the prostate. And the most important thing is that we need to be able to differentiate between this kind of hyperplasia from also some different kinds of low-grade cancers, especially. This is another example in which we have nodules as well. And you can imagine if these nodules grow and starts pushing against the urethra, they are going to produce several problems in regards to obstruction mostly, and the consequent pathology at the level of the bladder with distension of the bladder, and also hypertrophy of the muscles, hyperplasia of the muscles in the bladder. This is just a closer area of one of these BPH or nodules, usually associated with inflammation. And then we have what we call basal cell hyperplasia. In these cases, they are associated with significant atrophy. This would be the normal aspect of the configuration of a gland, where you can see here the glandular components. They are well kind of cylindrical cells, and then surrounded by this single layer of basal cells that sometimes they are kind of difficult to identify under a microscope, and we can use some special stains like P63 or high molecular weight cytokeratin. But then, according to the person aging, then the glandular cells become atrophic, and the basal cells become hyperplastic. So we are going to see sometimes cases like this, for example, that we shouldn't confuse with cancer. Most of these cells are basal cells, and the glandular cells are almost flattened. You can almost don't see them, but they are here in the center as well in this area. They are positive for high molecular weight cytokeratin, and this is a good way to make the difference in case that you have some suspicious to make the difference with cancer. And as you will see here as well, this area in the center are the glandular components that are not stained. They don't have this high molecular weight cytokeratin, but it's a very prominent hyperplasia of the basal cells. Then another important lesion to keep in mind, because this is the main uh, uh, differential diagnosis with cancer, these kind of lesions is the main mimicker of cancer, and we need to be able to identify them. They are usually with the same architectural configuration of a normal glandular tissue, but the only difference is that the glandular components have shrunk, and then they are just reduced to a single layer of these very flattened glandular components, and they are usually surrounded by side fibrosis and also chronic inflammation. These are just different examples of atrophy, some of them with corpora militia. And the important thing is that sometimes the same basal cells can become larger and with nucleoli, and also further creating some problems in the identification. Here we have some prominent basal cells around, and as I said before, we need to have a better trained eye to be able to make the difference. Sometimes this atrophy can be in the form of cystic lesions, as you can see here. They are also collections of or glands that become obstructed, and then they collect this secretory material and producing these cystic malformations. Anyway, so we go into the real malignant level, and now we have the classical cartoon where we can go from the normal cells that they become dysplastic and then become neoplastic, creating what is called carcinoma in situ, that is basically the high-grade prostatic intraepithelial neoplasia. And then when they break through the basement membrane, invading the stroma, is when we call them cancer. Here, there are some examples of this high-grade pin. They are usually multi-layer. The atypia is very evident, prominent nucleoli, very coarse chromatin, because they are already have a completely screw-up DNA. This is cancer. This is the only difference is that it's cancer that is still confined inside the gland, and eventually they can come out. The presence of high-grade pins has been debated through the years, but definitely we all believe that cancer starts at this level, and in general, the presence of one lesion in a whole set of biopsies may be not relevant, because the incidence of cancer in those patients is not going to be higher than the normal population. But to have more than one lesion in a set of biopsies may correlate with a higher chances for that patient that eventually during the course of his life is going to present cancer. So more than one high-grade pin lesion in a completely negative biopsy for invasive cancer, it has to be reported. And this will condition that this patient has to be followed up in a very close way with the control of this PSA, and as well with new biopsies sometimes every year. This is another area where we have another, the staining of the sample sometimes can be kind of tricky, but we see that these glands or these cells are enlarged. There's a higher nuclear cytoplasmic ratio. Sometimes the nucleoli are not very easy to identify, but you can go and find them in some cells and not others. For the diagnosis of high-grade PIN, we need to have at least 20 to 30% of the cells inside the benign gland, in quotations, with nucleoli. That is a good marker, kind of if we find one or two nucleoli here and there, we better let it go. We don't usually call it, but we have to have at least a good number, 20 to 30% of nuclei with nucleoli. In regards to the incidence, you can see here that many countries have very low incidence of prostate cancer, whereas Nordic countries, including the United States, we are the ones who really suffer the consequences of this disease. And this is very interesting, because when you have individuals coming from these areas to live in these countries, then the incidence of cancer is going to be increased. So this is not just a genetic factor, this is an environmental factor, and we need to be aware of that from the medical point of view, because when I was doing training in Peru in pathology, Arias Estela, who was the leader in our group, told us the secret of cancer eventually is going to be by knowing the epidemiology, because we are all susceptible to cancer, but in some areas we are going to be more susceptible, and our role as physicians is going to be able to identify what they are the environmental factors that can condition that higher incidence. So we have populations that are from the racial point of view, it's a mix of countries, of all these countries with low incidence, but when they come to live here, or especially in these northern countries, there is something in the water, to say it more simple, that is conditioning this. And here we have some just data to compare the median age at diagnosis of cancer. As you can see, at 67 years of age is when we have the peak of most of the cancers being diagnosed. And then we have, through the years, since 1992 to near this time, that has been a rate of new cases that has been reduced a little bit. But what is interesting is that during the last year, 2020, the famous COVID year, the incidence of these cancers and the death rate has increased slightly. And this is due to lack of medical attention. All the many patients we are finding very advanced cancers nowadays in our whole prostatectomies. Individuals who should have been treated earlier are now suffering the consequences of presenting more advanced cancer. Anyway, the 5-year relative survival, as compared with other cancers, is relatively good. We can say that about survival, and it's about 97.5%. So individuals who are later in life, for example, in the 80s or 90s, and we find cancer, we sometimes just let it go. We don't do any kind of radical procedure, because they most likely are going to die of something else, not of prostate cancer. It's interesting to mention that there is a significant racial differences. So if just trying to be in the mood of the current times, prostate cancer appears to be very racist, because it's attacking a specific population. For example, you compare Hispanic with non-Hispanics or with Black individuals, the incidence is significantly higher. You mix all races, it's an average, but here we can see that the Asian population, for some reason, they are a little bit more protected as compared with the African American population. And this can be gene related, cultural related, and probably most likely a combination. Also, in regards to the death rate, the race and ethnicity is also an important factor to consider, and also Black individuals have a higher rate of incidence of death due to prostate cancer, similar to the incidence that we see in the presence of this cancer. So when we do the gross examination, sometimes it's very difficult to find the cancer at the naked eye because the prostate itself doesn't get too much distorted. We can have a big tumor here in one side, and it's going to be kind of symmetrical with the other side. The only difference is going to be at the microscopic level. I'm sorry, I had this slides a little bit mixed up. But anyway, this should have been correlated with the previous slides in incidence, where the median age at death is about 80 years of age. Anyway, continuing with the gross examination, sometimes we can detect the cancer at the naked eye, as you can see here in this narrow. That is kind of a little, probably the imaging analysis, CT scan and magnetic resonance, a little bit more being developed more specific for the identification. So this is our world. We receive mostly biopsies that have to be processed properly. And as we mentioned before, we need to have as pathology a good communication with our laboratory to be able to have good quality of images. And one of the most important features for the diagnosis of cancer is first that they have a very high nuclear cytoplasmic ratio, very prominent nucleoli, and also the absence of basal cells. And also in regards to this architecture, uh, in the routine, I like to scan the slice at a lower power at 10x or 20x, just usually 10x, and then the architectural array of the glands are going to be the most important clue to be able to identify the malignant infiltration. Also, we can use other markers. We can see this is most at the level of research, comparing normal tissue with cancer in regards to proliferation if you use a Ki67 or MIR1 staining. Then this was the classical histological criteria for the Gleason grading developed by Dr. Gleason in early 60s. And he was able to classify in a very complicated way 1, 2, 3A, 3B, 3C, 4A, 4B. From all these differentiations, now we are just basically with only 3 different grades that are 3, 4, and 5, from which and this is the original classical drawing of Dr. Gleason trying to make the differentiation of these glands. That the most interesting achievement is that he was able to correlate the morphology or the architecture of these glands of this cancer with the survival of the patients. And that's the most important clinical correlation that we have from Dr. Gleason. But nowadays, we just have these Gleasons 3, 4, and 5 combined in these just 5 groups according to the new 2014 ISUP classification, in which you have here that the equivalent of group 1s with the different scores of Gleason. And the recommendation nowadays is to produce in our reports both classifications, at least for a while. The Gleason's, the rationale for the generation of these grade groups is because there was basically these groups scores like 1 + 1, 2 + 1, etc., up to 5. Basically, they were either benign atypical hyperplasia. And Dr. Gleason discovered that later on, many of these Gleason's scores, low-grade Gleason scores, when he was able to examine those cases using high molecular weight cytokeratin, many of them, they were just atypical hyperplasia, not real cancer. So the real cancer started with Gleason score 6, and then this Gleason 6 that they now belong to the group 1, because it was kind of a weird to call a patient, oh, you have a kind of a low grade. From 1 to 10, you have a 6. And the patient said, well, from 1 to 10, 6 is not low. It's just the middle. So it didn't have a good correlation in regards to survival and in regards to aggressiveness. So the group 1 that they are just now, the score 6, they have an excellent prognosis, and they are usually go into active surveillance, and we are more conservative. And then this prognostic impact has done in a multi-institutional validation with thousands of cases with radical prostatectomies, needle biopsies, and also following radiation. So this new grouping has been very carefully evaluated, and then nowadays we are just reporting them, but also the recommendation is to associate our reports with the Gleason scores. This is just for historical reference, and these were from all their publications in which they trying to represent what it was called in the past Gleason 1 and Gleason 2 in this particular case, and nowadays we call them Gleason 3. And then we have the new classification in the Gleason 3+3, when we have individual glands These glands are fairly uniform. They are just haphazardly infiltrating the tissue, and this is in contrast to the normal glands, and they are even smaller, and they have an infiltrated pattern. The most important thing is that they have nucleoli, and they have no presence of basal cells, and they also show good amount of lumen in these glands. When you see some glands like this, for example, that doesn't have a lumen, is because basically we are tangentially cutting the top of the gland and not reaching the central area. But in general, this is what we call Gleason 3, and this is another nice example of Gleason 3, just very independent glands and trying to reproduce their normal morphology. But then these glands become clustered and fused, and then this is a higher grade. The capacity of these cells to invade and to produce metastasis is significantly higher to what is called Gleason 3 that we have here at the left side. So this is a combination of Gleason 3 with Gleason 4. There is a slight predominance of Gleason 3 at this side, so the tumor is going to be called Gleason 3 plus 4, that corresponds to grade 2. And then here we have another one that we have some glands that are individuals, and then we, together with some other fused glands with the predominant Gleason 3, some of these glands, they are starting to take this kind of a tail shape, and sometimes it's difficult to tell if it is a 3-4 or a 4-3. And so this is a 60-40% or a 40-60% anyway. So, and so you have, the larger the amount of tumor that you have, probably the easier to reach an agreement in which one is predominant. Then this definitely this one has a predominant Gleason 4 with fusion, a lot of fusions. There are a few cells that are, or glands that are independent, so we can still call it 4 plus 3, but it's still a very significant amount of Gleason 4. In some cases, we can even call this like a 4 plus 4, because it's a very small amount of glands that represent the Gleason 3. Excuse me, I don't know what I did. We were here, okay. So anyway, and then we go to the pure Gleason 4 plus 4, where we are going to have these masses of glands. They try to form glands, but they are all fused with some cryptophore appearance. And then here we have some others. The presence of signaling ring cells can be seen inside this Gleason 4 plus 4, but as long as these signaling ring cells are within this mass, we don't call them Gleason 5. We want to have them independently away from these masses by themselves to call them Gleason 5. Okay, so here we have some Gleason 4 combined with Gleason 5. And as you can see, this Gleason 5 start to create kind of a more uniform sheets of tumor as compared with the Gleason 4 that still tries to represent some glands. The other clue for the diagnosis of Gleason 5 is the presence of necrosis, as you well know, even though this whole cluster here appears to be like Gleason 4, but with a cribriform pattern, but the presence of this karyorrhexis with necrosis definitely makes this the whole sample like Gleason 5. Here's another combination of Gleason 4, here mostly at the right side, with Gleason 5 at the left side, where there is almost complete loss of identification of this tumor with glandular morphology. There is no glandular array here, whereas here still some of them, they try to form glands. And when you see them completely on themselves, forming these little lines or single cells, this is just a pure Gleason 5 that is, as you know, very aggressive. All these cells have a very active amoeboid motility, and that's the reason why they easy to go out of the prostate. Don't forget that there is a very special uh, prostatic carcinoma that has a ductal origin, and it's called ductal prostatic carcinoma. And in many cases, even though they may look like Gleason 3, by definition, any kind of ductal is going to be called Gleason 4 plus 4 plus 4. They can be also present in mixed with some of the Gleasons, either Gleason 5 or Gleason 3. But the most important component, they are this kind of glands. They are very large with kind of more cylindrical uh, cells resembling prostatic ducts. Occasionally, we may find some differentiations of prostate cancer into squamous adenocarcinoma or carcinoma or adenocarcinoma. And in these cases, we need to have the differential diagnosis. If this case is this particular cancer is coming primarily from the prostate, or if it is cancer originated in the bladder invading the prostate. And this is another important, we can make a whole lecture about the differential diagnosis between prostate cancer and urothelial cancer, both in the bladder and in the prostate itself, and also at the level of the urethra. But continuing with these features in cancer, it's important to consider the perineural invasion. This was another controversial finding, especially when we find this perineural invasion in biopsies. At the beginning, the data show that the presence or absence of perineural invasion was not very much relevant. But in that case, they were combining results from prostate biopsies that were with only one perineural invasion or several foci with perineural invasion. But when someone else came in a more clever way and tried to differentiate the survivor or the incidence, all this was correlated with whole prostatectomy specimens later on. But when you had patients with only one focus of perineural invasion, the difference was not that significant in regards to the presence of extraprostatic extension in the whole prostatectomy. However, when you have more than one perineural invasion, that correlated in a very significant way with the presence of extraprostatic extension. So at this time, if we find only one perineural invasion, of course, we try to always mention it. But the most important thing is that you have more than one in two different cores, because those individuals are more likely, especially also the thickness of the bundle. This is a medium caliber bundle with this invasion, and in contrast to other small bundles that we can find, that they are less significant, but the thickness of the bundle also correlates with extraprostatic extension, and there are very nice papers about that. And this is another example. This is a small, and you need to find the tumor in the real perineural space. As you can see here, this tumor is just kind of surrounding this nerve. This is a typical perineural invasion. And don't be surprised that the appearance of the tumor in the perineural space is going to look like a higher grade. So you never grade a tumor that is in the perineural space, because they are going to, the whole tumor can have the morphology of Gleason 3, but just in the perineural area is going to have appearance of a Gleason 4, for example. So don't call it Gleason 4, just call it perineural invasion. It seems that the perineural space, for some reason, makes these tumors to look a little bit higher grade. And here's another case of perineural invasion where the tumor is really with intimate contact with the nerve surrounding it. The other aspect important to consider is the margins, and this is starting with the way that you gross the specimen with a good inking and a differentiation of the areas of surgical resection. And if you find tumor that is touching the ink, of course, the rest of the tumor is still in the patient. And here is another case of those kind of tricky cases where you see tumor and also with some areas of the tumor touching the ink, as well as here. Here, definitely this gland is being cut, and then we need to measure the size of the area that is involved, because it seems that the size of the perineural, excuse me, the surgical margin that is positive, it has clinical significance if it is less than 3 millimeters or more than 3 millimeters, and it is considered in your cap sheet when you fill out for a whole prostatectomy specimen. That is a point important to consider. When we find invasion of the fat, especially in core biopsies, that is definitely consistent with extraprostatic extension. There are just very few cases in the literature of individuals from autopsy cases, especially in a report from Australia, in some native Australian individuals, that in the autopsy examination, they've been found to have some fat inside the prostate. But in my experience, I've never seen fat inside the prostate. So if you find a needle core biopsy that it has cancer in the fat, you need to say at least that is consistent with extraprostatic extension, as well as you can see here in these examples. It's another important case that, and unfortunately, some of our colleagues in the private labs outside, when we receive their samples, they don't mention this fact, and they and I think that that's an important clue for the surgeons, so they can do a more radical resection in the area where the extraprostatic extension is being identified. This is from a whole prostatectomy, where you see a very overt invasion of the extraprostatic space, as well as here. Yeah, these are just our examples with perineural invasion and extraprostatic extension. Again, here, all the tumors around the nerves, and even some neurons in that area. So the use of these special stains, you are very familiar. We're going to be a little bit more, a little faster in this area, but the most important is to identify the basal cells, because we know that the tumors don't have basal cells, and in contrast, they have an increased number or increased concentration of racemase in the cytoplasm. And here we have some examples of, for example, for the high-grade pin, and then when we see them under the staining with the high molecular weight cytokeratin, we see that this gland is still confined, or this cancer is still confined within the gland. Here we have the atypical cells, cancer basically in situ, but it's still confined inside the basal cells. This is another case where it's suspicious for malignancy, and then when we do the staining, it turns out that it has focally basal cells. And this is a case of an individual who received radiation. And radiation, post-radiation therapy changes are very confusing sometimes in trying to identify if these glands are really cancer or not. And as you can see here, in the H&E, look very atypical and suspicious of cancer, but here they all have basal cells. So these are the real atypical cells with radiation-induced therapy. Here is another case where we have this little cluster, very atypical, and then in areas similar to that, they all had positive for basal cells identification. Here is another case that they were also post-radiation and with atrophy, that they were corresponding to benign tissue versus the suspicious atypia that we can interpret if we just made the diagnosis with the H&E. Sometimes we may find cases that are very suspicious for Gleason 3, for example, but when we do the high molecular weight cytokeratin, they do have basal cells, and this is what is called a typical adenomatous hyperplasia, that in the time of Dr. Gleason, that he didn't have these markers, many of these cases were considered Gleason 1 and 2. This is another case with cancer. This is very evident. And then when we do the high molecular weight cytokeratin, it's very easy to identify what is the benign gland versus the malignant glands. It's another case with a small focus in which we made a diagnosis of cancer just using these special markers. This is another one. There is a possibility of cancer here, and then when we do the high molecular weight cytokeratin, definitely that area corresponds to cancer, in contrast to our internal control of benign glands. And then our main mimicker of cancer is atrophy. So this, this is not a very good picture, but this was a case also where we have both Gleason 3 and atrophy together in the same milieu, and this is very important. With the other marker important for this discrimination is the P63, that is a nuclear antigen. In the previous case, we were talking about high molecular weight cytokeratin. I like to have both. We're trying to develop a system nowadays that instead of just doing P63 alone or high molecular weight cytokeratin alone, we can do them both together. And this is the famous racemase in those glands that have cancer. This is the different color, a famous pink cocktail, where you have here a benign gland with nice basal cells stained with both P63 and high molecular weight cytokeratin, and the normal glands or typical glands, but we still confined inside the gland, and cancer outside with high expression of great racemase with this granular appearance in the cytoplasm. And this is a case of an individual that was not very old. He was 30 years old with anemia, and they did a core biopsy, a bone. Oh, excuse me, it was bladder. I had another case that was in the bone. They look very similar, but this is Gleason 5 infiltrating unidural bladder, and which you can see the staining for PSA in that in that particular sample. PSA sometimes is also tricky, and not always is positive in cancer and prostate cancer, especially when it's being treated. And we have the NKX 3.1. I don't have a picture here, unfortunately, but this is another marker that is very important. And finally, we have the spreading of the cancer into the lymph nodes. This is just metastasis with extranodal invasion, and then the use of PSA for the identification of this cancer in these neoplasias. And this is the one for the bone that very easy to go to the bone. And this is the case that I was going to talk about, that we found in this individual 30 plus years old with anemia that was sent to hematology. So the hematologist did a core biopsy, a bone biopsy, and then we found this tumor. And we didn't know what it was because of the age of the patient. But then, for some reason, someone said, well, why don't we put a PSA? It was the only specific staining was positive for PSA. And then when they went to examine the prostate of this guy, he had a very high-grade cancer. Well, with that, I think that we have taken most of your time. And in case that you have any questions, I'll be happy. Either you can approach me in my visits to the AIP, or send me an email at any time. I'm always happy to work with all of you, trying to decodify this mysterious cancer that sometimes creates so many problems and anxiety in some of our residents when starting to do prostate pathology. Thank you so much. Still people alive over there?
Just barely. Thanks, Dr. La Rosa.
Okay, barely. Okay. Sorry for that. And okay, we'll see you soon. Thank you.
Have a good day.
You too.